Welcome back to the YourGoToDoc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon for over 25 years, and today we're going to talk about lumbar synovial cysts. They sound pretty nasty, but they're actually relatively benign, but they can cause significant pain and discomfort. So what we're going to do today is talk about what a lumbar synovial cyst is, how you get it, what it looks like on pictures, what it looks like on models of the spine, what kind of symptoms you'll get when you get a lumbar synovial cyst that's causing problems, and then finally what you can do to treat a lumbar synovial cyst, as well as the surgical option, what to expect before, during, and after that surgery, and the risks and benefits. So stick with us and we'll get to it about lumbar synovial cysts. Okay guys, so what probably happened is you've had backaches and pains for years, attributing it to getting older, the weather changing, joints wearing out, arthritis, etc. But then one day you start to get some leg pain. It doesn't go away. You go see your doctor, they get an MRI, and the nurse calls you to say your MRI came back and you've got a synovial cyst pinching your nerve in your lumbar spine. We need to send you to a neurosurgeon. What is a synovial cyst? Well, it sounds terrible, but in reality, a synovial cyst is just an arthritis cyst. And arthritis is just layman's terms for wearing out of the joints. So there are joints in your spine called the facet joints, and they are where the upper bone meets the lower bone, and it's kind of a pancake-looking joint. And that joint is just like your shoulder joint or your knee joint or your elbow joint. It's got two bones that are put together close. There's a layer of cartilage on the bone on each side. There's a ligament that wraps around that joint to keep it tight. But more importantly, there is a tissue called synovium, which is inside of that joint, and it secretes a fluid called synovial fluid that lubricates the joint. And that synovial cyst comes from a break in the joint capsule that allows that fluid to get out of the joint. And what happens is that fluid gets out of the joint and it creates an inflammation in that area, and the body, as in a way to deal with inflammation, kind of walls it off, and it creates a cyst wall around this pocket of fluid that's leaking out of the joint. Well, now you've got a little pocket of walled off membrane attached to the joint where there's a hole in it that allows the synovial fluid to get out. And what happens is something called the ball valve effect. You move around, the fluid is supposed to be contained in the joint, but instead of being contained in the joint, it escapes out. And once it escapes out that little hole in the ligament into the membrane-filled cyst, it can't get back into the joint. And that's called the ball valve effect. And that fluid, therefore, can keep building up. So the more fluid that synovial tissue makes, the more it can escape out into the joint itself, into the cyst itself, and then can't get back in the joint, and the cyst can get bigger and bigger and bigger. Now, eventually, you can run out of room for that cyst, and if it pinches a nerve, you can get sciatica symptoms running down your leg. So that joint is near the nerves that run through your spine. Now, there are situations, and I've seen this on MRIs, where the synovial cyst forms on the back side of that facet joint. There are no nerves near that area, so the synovial cyst really doesn't cause any neurological symptoms or pain running down your leg. You may have back pain because that joint is not functioning properly, but you're not going to have nerve pain because there are no nerves on the back wall or back side of that joint. The front side of that joint, however, is near the nerve that comes out at that level, as well as the nerve that will go down to the next level. And it all depends on where that synovial cyst is pushing on something that will decide what kind of pain you're having or what distribution of pain, numbness, tingling, or weakness you might have. So let's take a look first at a model of the lumbar spine where I'm going to show you where the facet joint is and where these cysts form. And then we'll take a look at some diagrams or pictures of what the facet joints look like in the lumbar spine and where synovial cysts occur and can pinch nerves. Keep in mind, I'm not going to do a separate video on this, but you can get synovial cysts in other parts of the spine, most likely the cervical part compared to the lumbar. Thoracic spine, you don't get many synovial cysts because there's not a lot of movement in those areas. The thoracic spinal segments are stabilized by the rib cage and the shoulder girdle. But in the cervical spine, you can get some movement and you can get synovial cysts. I have done surgeries on patients where they've had synovial cysts pinching nerves in their neck. Relatively rare compared to the lumbar spine, but it does occur. So let's take a look at some spine models to see what synovial cysts, where they're located. Okay, let's first take a look at a lumbar spine without the nerves, and that'll show us the facet joints really well. So this is a model of the lumbar spine, and this is the back of the spine here, and that's the front. And if we look at the back of the spine, we see these kind of pancake or hamburger bun looking joints right here. And this is called a facet joint. And if you notice, they allow some movement. There's one on either side. This is the left side. This is the right side of the spine. There's the spinous process back here, which are the little bumps you feel down the back of your spine if you run your hand down the back of your spine. And if you look, this is a joint just like any other joint. Two bones touching each other, layer of cartilage on the surface of each bone. There's a joint capsule that wraps around this, and inside this is synovial tissue creating synovial fluid for lubrication. So now let's look at a spine model with nerves on it or in it. So here you've got a spine model with nerves in it. So again, there's the facet joint. See it moving around a lot? Now if the synovial cyst is coming off the joint right there, it can bother this nerve here. So if, for example, this is the number 4 bone and this is the number 5 bone, this would be the number 4 nerve, and a synovial cyst at L4-5 on this side, high up enough, could cause an irritated number 4 nerve. If, however, the synovial cyst is right here, which is more likely, pooching off that joint, it would then hit the nerve running right here, which is the number 5 nerve, not the number 4 nerve. And in that case, your symptoms would be slightly different and a different kind of distribution down your leg. But this joint can have synovial cysts anywhere along that capsule. If it's back here, it's not touching any nerves and it's not going to give you any trouble. In here, L5 nerve pinched. In here, L4 nerve pinched. Sometimes the cysts get big enough that both nerves are pinched and you have to decompress this whole area. But we'll talk about how to fix that surgically in a second. But that is what synovial cysts, where they would be located in the lumbar spine if they occur, and how they would affect the nerves. So now let's take a look at what synovial cysts look like on some diagrams. Instead of how I showed you on the models, this won't be just the bones and the joints. This will be an actual picture of the cyst, so you'll be able to see how it can pinch nerves. So let's take a look at a diagram of a side view of the lumbar spine. This unfortunately doesn't show a synovial cyst, but it shows an upset facet joint. So these squares here are the bones of the spine or the vertebra. The spaces in between are the discs or the shock absorbers. Again, this is a side view of the spine. There's the spinal canal running down inside the bones, and these guys are the nerves coming out at each level. Here you can see a worn out shock absorber or worn out disc, which puts extra stress on this facet joint, making it unhealthy, irritated, probably causing micro tears in the capsule of the joint. If you compare that to a healthy joint right here, you can see this is kind of frayed looking. Here's a close-up picture of what that degenerated joint looks like. Above here is a close-up picture of a healthy joint. 2 bones, 2 layers of cartilage, and then the synovial fluid inside the joint giving lubrication. There is the ligament capsule that covers the joint, which gets little cracks or tears in it, allowing this synovial fluid to come out. So you can see it would come out here, and if it comes out in the hole here, it would pinch this nerve. If it came out on the back side of this joint, deeper down here, it would pinch the nerve going down here. But this is an example of what a degenerated joint looks like and where synovial cysts would pinch nerves from a side view of the lumbar spine. Now let's turn this spine on an end-on view, looking down the barrel of the gun, so to speak, and you're going to see another picture called an axial image of the lumbar spine, which actually shows a synovial cyst. So in this image, we see that kind of down the barrel of the gun or down the tube view of the spine. Here is the disc, seen end-on. Here's a healthy facet joint, seen end-on. Here's a degenerated facet joint, seen end-on. And you can see the fluid from inside this facet joint has squeezed out to form this cyst. Here's a nearby nerve getting pinched by that cyst. You can see the nerve on the other side doesn't look as narrow or is pushed on by that cyst. The fluid that can sneak into this cyst can't get back into the joint usually, and that's why these cysts get bigger. Little by little, as these joints move from activity, you squeeze fluid into the cyst, it gets bigger and bigger until it pinches the nerve. And that's what gives you that sciatica pain. Okay, so we just took a look at what synovial cysts look like on a spine model and then on some diagrams. Let's look at what these look like on an MRI. Keep in mind, you can't really see these cysts on x-rays or CT scans usually because they're really soft tissue type of lesions, whereas MRI will show them very nicely, especially the T2 weighted MRI, which shows fluid as a bright white signal. So let's take a look at what synovial cysts look like on MRIs. So here we have a sagittal MRI T2 sequence where fluid is bright white. And similar to the diagrams that we looked at first, this is a side view of the back or sagittal image. The squares are the bones. The stripes in between the squares are the discs. These little stringy things in here are the nerves, and this is the synovial cyst at the end of the arrow. It looks obviously like a cyst, a fluid-filled pocket, and that's coming off the joint that's in this area towards the back of the spine. So that's a sagittal image of the synovial cyst on an MRI. Here we have an axial image on an MRI. In this image, you can see the kidneys, left and right here. Here's the vertebral body seen end-on. Here's the nerve on the left side of the body. Even though it's the right side of the screen, it's the left side of the body. In the spinal foramen or hole that the nerve goes out of, here you can see the nerve on the right side being pushed on by the cyst. And you can actually see the cyst communicating with the facet joint. This hamburger bun looking thing here is the facet joint on the right, and the fluid in there is leaking out through a break in the ligament of the joint capsule, creating this cyst pushing on this nerve. So this is an example of a T2 MRI axial image showing a synovial cyst. We're going to talk about the surgery later on in the video, but in the surgery you'd come from the back here, remove a little window of bone in the lamina here, remove the inside of the facet joint here. That'll give you access to this cyst and the nerve, and you peel the cyst off the nerve and remove it. We'll talk about that in more detail in a little bit, but this is what an MRI looks like showing a synovial cyst. Okay, so you've gotten your MRIs, you've seen your doctor, symptoms aren't getting better, you've got back pain, it shoots into the buttock, down the leg in a particular distribution. Maybe you have some numbness and tingling. Maybe if it's bad enough, you've got some weakness. What do you do next? Typically, the first option you're going to go for is called conservative therapy, which if you've seen any of my other videos, I've talked about those in length, but it basically means anything but surgery. Anti-inflammatories, pain medication, physical therapy, muscle relaxers, heat, ice, massage, chiropractor, acupuncture, wearing a back brace, creams, rubs, patches, steroid pills, steroid shots, etc., etc. All of those things are great. Some of them will help, some of them won't, some will last, some won't. You could have two people with the exact same problem. One of those things will work in one of those people, but not the other. So it's kind of varied and not really predictable on which of those things will help or not. But I can tell you that with synovial cysts, conservative therapies tend not to be very effective, and that's because they really don't fix anything. They don't structurally change anything in your body. They certainly can mask the symptoms that a synovial cyst can cause, namely inflammation and irritation of the nerves, but they don't actually make the synovial cyst go away. So it's not a bad idea to try some of those things for a week or two. Just by chance you might get lucky. Synovial cysts have been known to spontaneously regress or go away. Do they get absorbed? Does the hole in the joint scar over and the fluid stops leaking out? Does the fluid pop out of the cyst and get absorbed into the surrounding tissues and the cyst never recurs? We don't really know. Some insurance companies may force you to wait a couple weeks anyway before they'd consider letting you fix this. But if you're not better in 1 to 2 weeks before you get your MRI and another week or so after the MRI, your primary care doctor or pain management doctor or chiropractor or whoever ordered that MRI that showed the synovial cyst is likely going to refer you to a spine surgeon, either a neurosurgeon or an orthopedic spine surgeon. So what will happen next? So you arrive in your surgeon's office to talk about removing the synovial cyst and your lumbar spine and unpinching those nerves. What would happen next? Well, the surgeon will probably examine you, check your reflexes, your strength, document how bad the nerve is bothered before the surgery. Depending on your age, you may get some x-rays of your chest, an EKG of the heart, some blood tests. Make sure you're healthy, make sure your kidneys work properly, your blood clots properly, your electrolytes are good. These are all things done to make sure you're as healthy as you can be for the general anesthesia that's needed for the surgery. Assuming everything looks good, you'll show up probably the morning of surgery. You'll meet the anesthesiologist. They'll bring you into the operating room. They'll put you to sleep, roll you over on your belly on a special table, wash the area of the lumbar spine with some special cleansing solutions, put over sterile drapes, and then start the surgery. Typically, there's going to be about a 1.5 to 2 inch incision over the area where the synovial cyst is. The surgeon will often use x-rays in the operating room to confirm they're at the right location where the MRI said the cyst was. And then they'll start the surgeries. So what's exactly involved in that surgery? Now, believe it or not, in the old days, synovial cysts were often treated with needle puncture. The physician that would be doing the procedure would guide a needle into the synovial cyst, which could be relatively difficult to do with the kind of imaging they would be using, because you're sort of indirectly assuming where the cyst is based on other imaging to guide that needle. And we are talking about spots that are near nerves. But they would guide a needle into the cyst, suck out the fluid. In the later years of using this treatment, they would inject something that would kind of maybe scar up the area a little bit. But those procedures were meant to decompress the cysts, which could be very effective for making your symptoms feel better. But what was found was that those procedures tended to be temporary. The cyst would just reform. So most surgeons or interventionalists have kind of gone away from sticking needles in lumbar synovial cysts to treat them, and they opt for more direct surgical options. So what is that surgical option? Well, the name of the surgery is basically called a lumbar laminectomy or laminotomy, medial facetectomy, and then removal of synovial cyst. So let's break that down. Lumbar, that means low back. Laminectomy or laminotomy is to mean to remove a portion of the lamina. On the spine model, that lamina is right here. This little bridge of bone right there. And that sort of cross-haired area that I marked on the spine is the area that would be removed. And that would expose the nerves underneath it. And then if you look at this facet joint right here, medial facetectomy means to remove the inside section of the facet joint, which would be this part here. So that creates this little window in the bone. So the next thing you're going to see, either above, below, or to the side of that section that you removed, are the edges of the nerve. And the edges of the nerve will be pushed on by that cyst. And hopefully you'll be able to see a border between the wall of the cyst and the wall of the nerve, or the membrane covering the nerve. And then you would basically dissect between the cyst membrane and the nerve membrane and remove the cyst, basically pull it away from the nerves. Sometimes you have to poke a hole in it and suck out the inside and then peel the wall of the cyst off. Sometimes the cyst just rolls off in a big ball. You can grab one end and just peel it off sometimes. The more inflammation that's been going on, typically the longer it's been there, the harder it is to peel that cyst off the nerve. There have been situations where the cyst was so stuck, the cyst wall was so stuck to the nerve that I felt that removing it could tear the membrane of the nerve and cause a spinal fluid leak, and we'll talk about that in a little bit. But anyway, once that area of bone is removed, the inside half of the joint is removed, and then the cyst is identified and peeled off the nerve, you're basically done. What I would like to do sometimes after that is I would cauterize the inside of the joint, of the facet joint, to try and scar up that joint so that the synovial tissue is kind of scarred over, or the joint itself is scarred over, and I believe that would lower the risk of another synovial cyst forming in the future. Knock on wood. I've never had a patient that I've done a synovial cyst surgery on who had a recurrence. That whole surgery to kind of get exposure to the cyst, remove the cyst, unpinch the nerves, probably takes about an hour, hour and a half or so. So that's the procedure to actually remove the cyst and unpinch the nerve. Let's talk about what happens after that. So you finish the surgery, you'll wake up in the recovery room. Your back's going to be a little sore from the surgery, but not terribly. You'll probably notice an immediate improvement in your leg symptoms if you had them before the surgery. Typically, pain will get better first, usually right away. Numbness and tingling can take longer, sometimes a few weeks. And weakness is the last thing to get better. That can take months to get better, and depending on how bad it was before the surgery, it may never get back to the baseline. Typically, what I tell patients with weakness is about a year after the surgery, you can kind of look in the mirror and say, this is what I'm stuck with. Some patients where the synovial cyst bothers a particular part of the nerve before the surgery, if they had a lot of buttock pain, they may still notice significant buttock pain after the surgery, after the nerve is unpinched, but typically it's better than it was before the surgery, and that usually gets better in a few days if you still have that after the surgery. But I would say the majority of patients that I would operate on for synovial cysts and pinched nerves wake up in the recovery room and they tell me their pain is gone. You'll be in the recovery room 30-40 minutes letting the anesthesia wear off. If you're not going to be sent home the same day, they'll typically let you go upstairs to a regular room about 45 minutes or so after the recovery room. Typically for my patients, I'll keep them one night in the hospital. That first night they just take it easy. They're allowed out of bed to go to the bathroom, but that's about it. The next day, the nurse will come in and change the dressing. The therapist will walk them in the halls, maybe up and down some steps. I'd be in around lunchtime. I'd look at their back. I'd ask them how they're feeling. And hopefully they'll say, my back's a little sore where the surgery is, but pretty tolerable. But boy, does my butt cheek and leg feel better. If everything looks good, I'll let them go home. 2 or 3 days stuck in the house. That doesn't mean lie in bed all day, but just stay home. They're allowed up and down steps, sit on the couch, watch TV, read a book, take a nap, play on the computer, stare out the window, watch the grass grow. That's for 2 or 3 days. About a week after the surgery, they can drive, short trips only, the bank, the post office, the grocery store, that kind of thing. But for 2 weeks, and this is the important part, even if they feel fantastic, I tell them they should be a slug for 2 weeks. No bending, no twisting, no lifting more than 5 pounds, no housework, no yard work, no walking the dog, no taking the trash out, no exercise, no sports, no hang gliding, no skydiving. Lay low for 2 weeks. The reason that's important is all those spots that I was working on during the surgery, I want to kind of scar over so that another cyst doesn't form, there's no excessive bleeding, that kind of stuff. I want everything to kind of solidify down in that surgical area, including the incision layers healing up. They'll typically be back in my office 2 weeks after the surgery for a checkup. I'll look at their incision. If they had any staples or stitches, those will come out. If everything looks good at 2 weeks, I will then let them slowly add their activities back little by little over the next 4 weeks, typically starting with the small stuff, working their way up to the big stuff. Which means by 6 weeks after the surgery, if everything feels good, they should be pretty close to their baseline. I'll warn them that that joint in that back part of the spine is still not a healthy joint. That can lead to back pain and muscle spasms if they do things the wrong way or do too much. So I still remind my patients at their 2-week checkup that they have a weak spot in their back and they still need to practice good back ergonomics and make good choices. And that means bend with your knees, not with your waist. Try not to bend anything while twisting. Try not to lift anything too heavy. Avoid high impact activities, those kinds of things. Now, could they get away with some of those things? Yeah, it's possible, but they are at greater risk for bothering their back than someone who didn't have the problems that we know they have. So I basically tell them to behave themselves from now on and always keep it in the back of their mind that they need to be careful with their lumbar spine. So that's pretty much what to expect after the surgery for my patients. The last thing to talk about are the risks of the surgery. There are 3 risks to any surgery. It doesn't matter what kind of surgery it is. Same 3 risks: infection, bleeding, problems with anesthesia. All very low, especially for this kind of surgery because it's not a big or long surgery, but those risks are in the books, so we have to tell you about them. And that's why we get the blood test, the EKG, the chest x-ray, all those kind of things before the surgery to make sure you're healthy. There are a couple of risks that are special to this surgery because it's spine surgery in the lumbar spine. One risk is injury to those nerves. We're working near them, we're unpinching them, we're peeling cysts off of them, we're removing bone and ligaments from around them. There's a risk we could hurt those things. Now, granted, that's a very low risk, but it's in the books, so we have to tell you about them. And if, God forbid, that did happen, the injury to the nerve would be something like weakness or numbness to whatever area or muscle groups that nerve supplies. The second special risk is something called spinal fluid leak. Now, that's a risk for any kind of surgery near the lumbar spine and the nerves, but it's particularly significant for this kind of surgery because, again, those synovial cysts stir up a lot of inflammation, and the wall of that cyst can get very stuck to the membrane that covers that nerve. So you have to be very careful about separating that membrane from the nerve or peeling the membrane off the nerve. If it's too stuck, and as a surgeon you get a sense that it's not going to peel off, you can kind of excise that cyst wall from the rest of the cyst, remove the cyst, and leave that thin layer of cyst wall on the membrane of the nerve. Without the cyst behind it and pushing on it, the nerve's not pushed on and not bothered. So that little layer of cyst wall stuck on the membrane covering the nerve isn't really going to cause symptoms. But that's where experience and being careful and treating everybody like they're your father, mother, brother, sister kind of thing helps with knowing, what is the right touch for peeling that cyst wall off and knowing when to stop. And if you have to leave the membrane there, leave it. If you do get a spinal fluid leak because you've torn the membrane of the nerve, typically you see that right away. It's like clear fluid leaking out of the spinal sac. There are lots of ways to fix that. You can put a little stitch in it, put a patch on it, you can glue it. Again, many ways to fix that. Again, relatively small chance overall, slightly higher for this particular problem, but it's in the books, so I have to tell you about it. And those are the risks of that surgery. So we've talked about what a synovial cyst is, what it looks like on a spine model, diagrams and imaging, what your other options are besides surgery, which basically is conservative therapy, which tends not to work very well, the surgical option and what to expect before, during, and after that surgery, and the risks. I hope that was informative. I hope it made finding out that you have a synovial cyst pinching a nerve less scary. And hopefully this video will make you better prepared for your visit with your neurosurgeon or your spine surgeon. And if you felt this was helpful, please remember to like and subscribe to my channel. More videos coming up. And again, thank you for watching the YourGoToDoc YouTube channel. And don't forget, stay healthy.